Hello? Hello? Can you guys hear me? Hello?
Yes.
Okay, that's perfect. So today we are going to discuss the topics which were covered in immunology. So can you guys just remind me those topics? What were they? Hello? Hello?
Doctor, I'm here, but I don't know the topics.
Okay, okay. So I think we were left with transplant rejection. Have you guys did transplant rejection with Dr. Moaz?
Yes, sir, we have done that.
Okay, you have done transplant rejection. Respiratory burst. Okay. Have you did
Anybody
in
have
No,
type?
sir.
any
No,
T-cell?
sir.
No.
So
Have
can
you
we
did
discuss
transplant?
the immunodeficiencies?
Immunodeficiencies, pathologies, right?
Yes, sir.
Pharmacology. So, what do you
Even
guys want me to
transplant
start?
rejection is not done. He just explained hyperacute, but not others.
Okay, so what do you guys should just vote? What topic should I start today first? Pharmacology, transplant rejection, or immunodeficiencies?
Sir, I think the immunodeficiencies are
Immunodeficiency was done
technical.
actually.
Transplant rejections are easy, but the immunodeficiencies are like easy. That's
So yes, respiratory burst. We are going to do that as well. No worries. Okay. So let's do immunodeficiencies, right? Let's start
Yes.
with immunodeficiencies, and we are also going to do the transplant reaction, no problem. And I'll just try my best to do pharmacology as well, right? If you guys are here, if you guys are enjoying, I'm gonna do that. Okay. So okay, just give me a second. First of all, let me just open. Okay, so what's the first aid page for immunodeficiency? Can anyone just tell me the first aid page number?
114.
It's 100. Okay, perfect. So let me share my screen first. Okay, so can you guys just see my screen? Hello.
Yes, sir.
Okay, perfect. So let's start with our first pathology, that is X-linked A gamma globulinemia, right? So first of all, we are going to break down the name of pathology and whatever knowledge we have. First of all, we are going to think what might we expect according to this name, right? Okay, A gamma globulinemia. A
Dr.
we know.
Ahmed,
Yes, please.
uh, mm, if it would be better if you start with phagocyte dysfunction because Dr. Was actually covered this B cell and T cell and B and T cell combined disorder. He's left with the phagocyte dysfunction. If it is possible, can you start with phagocyte
Sure.
dysfunction?
Okay. Okay. Let's start with that. Okay.
Thank you.
Okay. Let's start with phagocyte dysfunction. Okay. Perfect. So you guys know that. Okay, what are leukocyte adhesion deficiency, right? Before discussing that, let me just give you a general overview, right? After that, everything is going to be really easy for you guys. Remember, for example, if this is your tissue, right? Okay, let's see this. Okay. For example, if this is your tissue, right? And let's suppose, for example, if it's skin and you have a cut on skin, right? The skin is cut due to any reasons, right? And the bacteria just enter into your skin, into your tissues, right? We know that the acute phase white blood cells are going to be your neutrophils, which should come to the site. Am I right? Hello?
Yes, sir.
Neutrophils should just come here towards the site where we have bacterial growth or where we have infection, and we know that neutrophils are basically present within the blood vessels. So how did neutrophils come here to the site from the blood vessels? That's really interesting phenomena, right? We know that the neutrophils, first of all, they are going to be moving here and there in the blood, but once they are called upon here towards the tissue, you guys know the factors which are going to attract your neutrophils. Yes, what are the factors? Interleukin 8 attract neutrophils. What else attract neutrophils? Leukotriene B4, right? And what else on the complement?
C5A,
C5A,
C5A.
C5A
platelet
calciferin,
activating.
PAF.
Okay, perfect. So these mediators would just call upon these neutrophils from the blood vessels toward the tissue. But how does that occur? That's really important. First of all, as you know that the neutrophils are running very fast. First of all, in the blood, right? First of all, we have to slow them down. First of all, we have to slow them down, right? And then we have to move them towards the periphery, right? towards the periphery because we need these neutrophils to come here, right? So first of all, we have to slow down the speed of neutrophils. They are going to go into the periphery. This process is basically known as margination. They come to the margin of your blood vessels, right? And there we are again going to further slow their speed, right? Because we need them to get into the tissues, get into where we need them, right? So as they are being slowed down, so first of all, in the slowing process, first of all, they are going to be slowed down. They are going to start rolling. They are going to start rolling. And ultimately, a time would come that some adhesion molecules are going to be expressed there, and they are going to catch these neutrophils on a single site. And once we catch these neutrophils here, then the neutrophils are going to be migrated here, right? So we have PCAM, ECAM, P-selectin, E-selectin. If you guys remember, P-selectin and E-selectin basically are going to bind them. And via PCAM and ECAM, they are going to be transmigrated. What do we mean by transmigration? We are going to migrate them from the blood vessels into the tissue. You have a U-word MCQ on that. PCAM and ECAM. What's the function of PCAM and ECAM? They're basically going to cause transmigration. Okay, so what is transmigration? Transmigration basically is, taking these neutrophils from the blood and migrating them into the site of infection. Is it clear? Hello?
Yes.
Hello?
Yes,
Okay.
doctor.
For example, if we do not have the adhesion molecules there, so can you just stop neutrophils? Can you just catch neutrophils? No. If you cannot catch neutrophils, can you migrate neutrophils into the tissue? No. Right? Hello? Does it make sense?
Yes.
Okay.
Yes.
So now let's read this pathology, what's happening here, right? So till now we discussed leukocyte adhesion deficiency. If we have deficiency of those adhesion molecule, we cannot not catch neutrophil, and we cannot, put them and transmigrate them into the site of infection. So let's see what's happening, right? So this is basically going to be autosomal recessive defect in LFA1 integrin. LFA1 integrin. Just memorize it, CD80. And as a result of that, what would happen? You have impairment of migration. You cannot migrate the neutrophils into the site of infection. Okay, that's so simple. Okay, do you guys know what is pus? Pus is basically debris, a debris consisting of neutrophils, killed neutrophils and killed debris, right? So if you cannot transport neutrophils into the site of infection, so would we be having pus formation?
No.
Oh, no. Okay. In order to separate the, umbilical cord or placenta, basically we need neutrophils function because neutrophils eat things, right? So won't we be having delayed separation of umbilical cord? Hello?
Yes.
Yes, we will be having that, right? Okay. Another thing, dysfunctional neutrophils. Neutrophils are still going to be dysfunctional because there isn't any function of neutrophils if you cannot take it to the site of infection. That's the way you should think of, right? And recurrent skin and mucosal barrier infections. It's obvious that neutrophils have a lot of it have a lot of role in order to clear off. Our skin and mucosa is exposed to a lot of bacteria. Every time skin is exposed to your surrounding environment, and you can have a lot of bacteria, anytime present in your skin as well as in your mucosa. For example, if we are eating things, we basically ingest more than 5,000 of bug with the clean food which we are eating, right? So if the first line defense is gone, neutrophils are going to be, a kind of first line defense, right? They're going to be the first one coming towards the site of infection. Macrophages are going to be the second one. If you guys remember, we discussed that in our cardiology. We discussed it on a lot of inflammatory process. The neutrophils are going to be the first coming. After that, it's going to be followed by the activity of macrophages. So you can simply think of those barriers which are more exposed to bugs are going to be affected more if you are just knocking off the first line kind of defense, right? So that is your recurrent skin and mucosal barrier infection. Is it clear? LFA, okay, LFA1 integrin. Leukocyte adhesion, LFA1. Is it clear? Hello?
But
Yes.
If we do
that
not have adhesion molecules, so you can just put a lot of chemotactic factor, but still you cannot get them to the site of infection because we need that adhesion molecule. We know that, right? So whatever is the concentration of C5a, interleukin 8, leukotriene B4, very important. They're going to ask you on the U word this exact leukotriene B4, right? It attracts your neutrophils, right? So you can see if the neutrophils aren't moving to the site of infection, it's obvious they're going to stay in the blood, right? So what would happen to the level of neutrophils in the blood? It would rise. Okay. Hello? Hello? Are you guys here?
Yes, sir.
Okay,
Yes, sir.
perfect. And as a result of that, we'll be having a lot of infections with impaired wound healing, because for the wound healing we need acute inflammatory process in order to clean out the debris and everything. So is this pathology clear? Any questions?
No, okay.
No, perfect. Okay, so this is the way how you should just think of these pathologies, and then you don't have to memorize each and everything, right? You should know the basic concept and just build your concept upon that. The next one is Shediac Higashi syndrome. Okay, let me just make it really easy for you guys, right? Shediac Higashi syndrome. Remember, for example, if this is your cell, you know, inside the cell you have something called microtubules, right? Small kind of microtubules. Okay, small kind of microtubules. And what are the function of these microtubules? These microtubules basically transport things within the cell, or between the cells, or to the outside environment, right? So simply you can imagine that these are the cars or transporters present within the cell, right? These are the transporters which are present within the cell. Is it clear? Hello?
Yes.
Yes.
For
Yes.
example, if we just knock off these transporter, it means we cannot transport a lot of things. What? For example, we cannot transport the toxic things out of the cells, right? The toxic things out of the cells cannot be transported, right? Okay.
Yes.
Okay. We know that what is
Yes. Yes.
melanin. Do you know what is melanin pigment? It's a big, a black pigment, right? Melanin, melanocyte are basically going to, make melanin.
Yes.
Remember, in order to transport melanocytes or melanin, still you need this transporter. These cars are really important to transport them, right? So, for example, if I have any problem with these microtubules, can you transport the melanin towards their side? For example, to the ears, here are black, they need melanin.
N-
Can you transport them? No,
No.
No.
right?
No, they're too big.
So these are the two things you should just keep in mind. Toxic things are going to be built up in the within the cell. Why? Because we do not have the transporter, the microtubule to catch them and dump them out of the cell. We do not have cells, the melanocytes, to be transported into their specific location. So now you should know whenever in the question stem you are seeing some toxic things, some like neurodegeneration, neuropathy, things like that. Why? And along with that, they're just telling you we have an individual, same individual with gray hairs. What should you be thinking of?
Gray
You
hair.
should be thinking of cardiac
Oh,
Kagashi. Let's discuss it, okay? So basically, it's a lysosomal trafficking regulatory LYST. Just remember LYST. Okay, once the LYST is affected, what would happen? The microtubule dysfunction. We're going to be having microtubule dysfunction, right? And if we have microtubule dysfunction, we're going to be having progressive neurodegeneration. Why? Because in the neurons, the toxic things can build up. You cannot transport them, and that can lead to killing of your neuron, neurodegeneration. That's all. Neuropathy as well, peripheral neuropathy. Again, you cannot transport the toxic things out of your neurons, which is going to lead to peripheral neuropathy. Is it clear? Albinism. That's going to be a partial albinism, right? Okay. So
Yes.
albinism, why? The lack of
Because of
melanin pigment is albinism,
melanin.
right?
Yeah. Yeah.
Perfect. We cannot. Okay. Lymphohistiocytosis. What are lymphohistiocytosis? Do you guys know that? Hello. Okay. What are histiocytes?
Uh,
Just
your
in
in
macrophages.
in macrophages.
macrophages of your connective tissues are called lymphohistiocytes. Okay, so you can just simply think of that. These microtubules functions are also important for carrying your macrophages towards the side. This should be a concept which would just help you remind this lymphohistiocytosis. But the main important things are neurodegeneration. If you guys see in the question stem, albinism really important, and peripheral neuropathy, right? Okay.
Yeah.
And besides that, we can also have like pyogenic infections. That's quite clear that why. Because still within the cell, you cannot transport things. For example, if it's, let's suppose, your neutrophils, or if it's macrophages, you cannot have proper, transport or phagolysosomes formation. How do we form phagolysosomes? How the phagolysosomes are made? We already know that the macrophages is first of all going to eat an antigen. Then what the antigen is going to form? Phagosome. Then we have to combine this phagosome with lysosome in order to destroy the bug. You guys know that, right? The cord factor was one which was inhibiting your phagolysosome function. Remember?
Yes.
TB.
Yeah.
Okay,
TB.
Yes.
silicosis. Remember, silicosis was also doing that. Okay.
Yes.
In Shediac
Yes.
Higashi
Yes.
syndrome, again, You cannot fuse them. It means for the fusion of phagolysosome, still you require these microtubules, right? So you'll be having pyogenic infections as well, okay? Is it clear? So, okay, we are going to be having giant granules, okay, in the granulocytes and in the platelets. What are granulocytes? Neutrophils, eosinophils, basophils, and platelets as well. Okay, platelets, just keep that in mind. Pancytopenia, the idea is really simple. All of the dividing cells are going to become, kind of, they are going to, be dying. Why? Because the toxic compounds are going to be keeping on accumulating in them. You should just think in this way, okay? And there would be a mild coagulation, defect as well, because you can simply
Because of
think
platelets.
that maybe you can simply, yes, due to platelets, right? The platelets aren't,
Yes.
again, they are being destroyed due to accumulation of these toxics. So this is just two things you should just keep in mind. Microtubules help in transporting things, help in transporting, the toxic materials out of your cell, help in transport of, your melanocyte to your site. So this is the picture which is really high yield. Your UWorld is going to give you the same picture with a history of neurodegeneration, with a history of, gray hairs. Gray hairs is albinism, right? Partial albinism. Okay, and along with
Yes.
that, with pyogenic infection. So what should be your diagnosis? Shirdiak-Higashi syndrome. Is it clear?
Yes.
Hello? Perfect. Do you guys
Yes.
have any questions? LYST. Just remember LYST, okay? The next one is chronic granulomatous disease. Okay. Before discussing chronic granulomatous disease, we have discussed a lot of time what is granuloma, right? The first thing, whenever your macrophages cannot eat anything, whenever macrophages cannot destroy anything, what would it do? It would just make a granuloma. Okay, this is going to be one of your
Yes.
UWorld MCQ. Keep that in mind. Okay,
Yes.
whenever your macrophages cannot eat anything, it would just make a granuloma. What is the concept of granuloma? Because as it cannot eat the bug, but yes, it can create a physical wall, in order to avoid the spread of this bug towards to other sites, right? So that's going to be
Yes.
granuloma. So in the UWorld, they're going to be asked you, we have an individual, he has sarcoidosis, this and that, granuloma question, you can easily diagnose them. But they're going to ask you this concept that in the granuloma, we are going to be having live bug or live antigens. Okay, because we know the first criteria for granuloma formation is that macrophages cannot eat them. Is it clear? So we
Yes.
will be
Yes.
seeing the bugs inside the macrophages or inside the granuloma, because it's, you can simply imagine, it's a kind of physical wall, physical boundary in order to spread their out. Is it clear?
Yes.
Hello. Okay, we
Yes.
discussed.
Yes.
Okay, respiratory bus. One of the doctors just told me explain respiratory bus. Okay, so let's do respiratory bus, and then I'll be just coming towards this, this topic. Okay. Okay, respiratory bus. What is respiratory bus? Remember, the name indicates respiratory bus. It means that respiration is going to play some role in busting. What do you mean by busting? Bust is, tearing something, right? Or breaking something or destroying something, right? So respiratory bus means
Yes.
whenever, okay, in respiration we use oxygen, right?
Yes.
Hello? Oxygen is the
Yes.
main, whenever you see the word respiration, you would just think of, yes, oxygen, entering into the cell, carbon dioxide being released. In the respiratory bus, with the help of oxygen, we are going to make oxygen reactive species. Oxygen reactive species. And once those oxygen reactive species are formed, those are very reactive. They are going to cause lysis of bug. They are going to burst the bug. They are going to kill the bug. Respiratory bus. Is it clear? For the formation of those oxygen reactive species, we need an enzyme. What's that enzyme? An ADPH oxidase complex. Is it clear?
Yes.
Perfect.
Yes.
Okay. So, okay, this was your respiratory bus. You guys can just read it. The idea is very simple. Here you have myeloperoxidase, right? So myeloperoxidase is also an enzyme which is used to, tackle the bacteria or kill the bacteria. So you guys might have done an MCQ in your U world. If you guys remember, we have an individual with pneumonia. He's having a green sputum. What do you think? Why do we have the greenish color of that sputum? It's due to increased activity of which enzyme? Yes. Just tell me, please.
Myeloperoxidase.
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 Perfect. Perfect. You guys remembered it. Okay, that's great. So, okay, so here you guys can see what happens in chronic granulomatous disease. Again, it's defect of NADPH oxidase. If we do not have NADPH oxidase, it means we cannot form oxygen reactive species. If we cannot form oxygen reactive species, it means that we cannot kill an antigen or a bug. Is it clear?
Yes.
Okay.
Got it.
If we
Yes,
can,
ma'am.
okay. So individual with NADPH oxidase deficiency or defect is going to be prone towards having which kind of bugs invasion that are going to be
Catalase.
catalase positive.
Catalase positive.
Catalase positive. Can you guys just name the catalase positive bugs? Really important.
Asorius, Serratia, Aspergillus, H. pylori, Borrelia burgdorferi,
Mm-hmm. Borrelia. Okay. So nocardia, serratia. What else? Aspergillus, right? Your
Yes.
streptococci and one start with B.
H.
Staph aureus.
pylori,
Warriors.
The one starting from B. What's the name of that?
Borrelia burgdorferi.
Burkholderia, Bordetella
Bacteria
pertussis,
fascia.
Okay. What's the name of that bug? Who is going to be telling me? Starting with B.
Burkholderia,
Okay, that's the bug. Okay, that's the bug. Remember. Okay, so you're going to be having a UL MCQ on that bug, right? Just remember that. They're
And
going to be
Candida
giving you
as
sir,
the
well as
same scenario.
which bug?
Candida.
The one start with B. The one start with B. Okay, your Burke, something like that. Okay.
That
Burkholderia.
is Burkholderia.
Yes, that Burkhold area. Yes,
Burkholderia.
AHOLDA. Okay,
Burkholderia. Yes.
Burkhold area. Okay,
Yes.
that's the catalase positive bug. Keep that in mind. Nocardia, Serratia, your Aspergillus, your what else? That's your Staph aureus, right? Hello,
Yes.
Staph. Okay,
Yes.
Yes. Yes.
so keep that
Yes,
in
sir.
mind. That's really important. These are the two tests which you should just memorize, right? Memorize. Whenever you see these tests, just go. You should just think of they're talking about this pathology, right? What test? Abnormal dihydrorhodamine, that is decrease green fluorescence, decrease green fluorescence of flow cytometry, right? And nitro blue tetrazolium dye reduction test fails to turn blue. Okay, it's something you have to memorize, right? Abnormal dihydrorhodamine test decrease green fluorescence. Abnormal di okay, just repeat it, okay? 2 to 3 times you guys would know. Abnormal dihydrorhodamine decrease green and nitro blue tetrazolium dye fails to turn blue. That's all. Whenever in the question stem, they're just telling you we have an individual with this and that, and there was abnormal dihydrorhodamine test decrease. It's really important. You are going to see an MCQ in your NBMEs as well from this same thing, right? So from these same tests, so just memorize it, okay? Is it clear?
Yes.
Okay, these were the immune deficiencies which were left. So what's going to be okay? So let's discuss. Okay, what else was left? Hello, hello.
I think the pharmacology was also remaining.
Okay, let's do pharmacology now. Okay, okay. Pharmacology was remaining. Okay, so let me just draw here. Okay, for example, if you have your antigen presenting cell, okay, you have antigen presenting cell. Antigen presenting cell have which receptor? MHC class 2, right? Hello. It's going to interact
Yes.
with which receptor? Just please, guys, just be, just wait.
CD4.
Okay, okay. Just give me a
CD4.
second. Just give me a second, please. Okay. Okay. So we discussed. Okay. Just give me a second. I think I lost my screen. Okay. Can you guys just see my screen?
No, sir.
No, no. Okay. So we are going to do these immunosuppressants on, really good. You guys are going to understand. Okay. So, okay. So can you guys just see it now?
Yes.
Okay,
I
Yes.
can
perfect.
see.
We discussed we have antigen presenting cells. They have MHC2. MHC2 is going to interact with which receptor? CD4
That
positive
is for
receptor. Helper cells. What's the other co-stimulatory? Mm-hmm. 28 and
Uh,
B7, right? 28 and B7, right?
Yes.
Yes, yes.
yes.
Yes. B7 is also CD80 and 86, something like that, right? Or 88. What's that? Okay, perfect. You guys know that, right? What would how? Okay, once we discussed that antigen presenting cells is going to bind to MHC2 is going to present things to MHC2. MHC2 further is going to interact with your CD4 positive T cells, and once they interact with your CD4 positive T cells, The T cells can have Th1 response or Th2 response, or they can have interleukin 2 being released, and it can cause autocrine effect, that is proliferation of your T cells. It can cause a proliferation of your natural killer cells, proliferation of your CD8 positive T cells. Remember, so it means that interleukin 2 was responsible for growth of your T cells. Can I say that?
Yes, sir.
Hello. Okay, so how
Yes,
does
sir.
that happen in the cell, in the T cells? We are going to discuss that. Okay. So, for example, if this is your T cells, you have something called calcineurin, right? Calcineurin. So once the signal comes from your antigen presenting cells, calcineurin is going to be activated. What calcineurin is further going to do is going to release something called nuclear factor of activating T cells, something like that. NFAT, right? Okay, nuclear factor of activating T cells. What the NFAT is going to do, it's going to enter into your where where into the nucleus, right? Into the nucleus, into the DNA, into the genes. It's going to activate some genes which would make your interleukin 2. Does that make sense?
Yes.
Hello? Because interleukin 2 comes from your, from your genes, from your nucleus, right? Okay, so it would lead to activation, or it would lead to formation of your interleukin 2. Interleukin 2 would just come out, interleukin 2. We discussed the story of interleukin 2. They have an autocrine effect. They can act on the same cell, leading to proliferation of T cells. They have the paracrine effect. They can act on the neighboring T cells, leading to proliferation of those cells. They can act on the natural killer cells, leading to proliferation of the cells. Is it clear? How does it do that? Once the interleukin 2 binds to the receptor, okay, for example, if here we have a receptor for interleukin 2, right? So interleukin 2 would bind
Yes,
to the
sir.
receptor, and further it would just activate something called mTOR. mTOR, right?
Yes.
Is it clear? And that mTOR
Yes.
is basically responsible for growth of your T cells. In the end, you will be seeing growth of T cells. Is it clear? Hello?
Okay. Yes, yes, sir.
Okay, let's discuss it again. Antigen presenting cells, MSC2 interaction with CD4, it's going to activate the calcineurin. What calcineurin further is going to do, NFAT. NFAT is going to go into, transcription. It's a transcription factor. It's going to, cause activation of genes, which is going to make your interleukin 2. It's going to act again in the autocrine effect, if you guys remember. On the same cell, it's going to activate the mTOR, and mTOR further is going to lead to the growth of T cells. That's a simple pathway. If you guys know this pathway, you guys know the drugs. Okay. So if I'm inhibiting calcineurin, it means I would be inhibiting the T cells growth. Am I right?
Yes.
Yes.
Yes, yes, sir.
Okay. If I'm inhibiting calcineurin, it means I'll be inhibiting the growth of T cells, right? I won't be having NFAT. I won't be having activation of genes. I won't be having interleukin 2 coming. I won't be having mTOR. The entire pathway is going to be blocked. So we have two drugs which blocks calcineurin. That is cyclosporin and tacrolimus. Cyclosporin and tacrolimus, right? But
Yes.
these drugs directly do not go and inhibit your calcineurin. They have to combine with something in the cell. And what's that? Cyclosporin is going to combine with cyclophilin. And once it combines with cyclophilin, then it's going to inhibit the calcineurin. Is it clear?
Yes.
Yes, sir.
The tacro will just combine with FK506 and something BP like that. Okay, something like that. Okay, FK506. And once the tacro combine with FK506, then it's going to lead to inhibition of calcineurin, right? Is it clear?
Yes, sir.
Okay. If we are inhibiting calcineurin, it means we are suppressing the T cells. We are suppressing the T cell growth. So can I say that these drugs can be immunosuppressant?
Yes.
Yes.
Okay, perfect. That can be immunosuppressant, right? For example, if I want to suppress the immunity, if I don't want the T cells to destroy my transplanted kidney or transplanted anything, so I would be giving these immunosuppressant in order to suppress their immunity, in order to decrease the chances of rejection. If you guys remember, the chronic rejection and acute rejection involve type 2 and type 4 hypersensitivity. Remember? Type 4 for T
Yes.
cells.
Yes.
So let's inhibit T cells and let's avoid the rejection. Okay. But what's the side effect of these drugs? That's really important. Both of these drugs are nephrotoxic and neurotoxic. So interesting phenomena is that still we are going to give it for the prophylaxis of kidney transplantation rejection, right? It causes nephrotoxicity, but still we are giving them. Is it clear?
Yes,
Hello?
sir.
It can
Yes,
cause
sir.
neurotoxicity, they can cause neurotoxicity, they can cause nephrotoxicity. Remember two things: neurotoxicity, nephrotoxicity. Okay? Hello?
Yes, sir. Yes,
Is it
sir.
clear?
Yes.
Okay. Okay. What else cyclosporin can cause? That's really important. It can cause two other things, right? It can you have two other adverse effect of cyclosporin. That are it can cause hirsutism. It can cause hirsutism, and it can also cause gingival hyperplasia. Gingival hyperplasia. Gingival hyperplasia was one of the important feature of a drug. If you guys remember something, that was
Phenytoin.
about
Oxygen.
Anesthesia.
phenytoin, perfect,
Phenytoin.
right?
Yes.
But the second one, which which you guys should just keep in mind, is your cyclosporin. The second one is cyclosporin. Okay, is it clear?
Yes,
Hello.
Yes.
sir.
Okay.
Yes.
So, for example, both of them are, like the inhibitors of calcineurin. But okay, both of them are like inhibitors of your calcineurin. But you can see, okay, just please give me a second. Okay, someone is just give me a second. I'll be back in a minute. Hello.
Yes, sir.
Yeah.
Okay,
Yes.
so we were discussing that both of them are basically inhibitors of your calcineurin, right? But from the question stem, you can have an idea whether we are giving cyclosporin or tacro, seeing the adverse effect, right? What are the other adverse effects? They can cause hypertension, they can cause hyperlipidemia. We'll be discussing that in our, once we are reading the first step. But this should be the general overview which you guys should just keep in mind. Is it clear?
Yes, sir.
Okay.
Yes.
Okay. Then you also have okay. Okay. We discussed we can block calcineurin, we can inhibit, the proliferation of your T cells. What else we can do? We can also block this mTOR, right? Hello?
Yes, sir.
Okay.
And
Yes.
the
Yes, sir.
drug which blocks mTOR, what's the name of that? That's going to be your
Yeah.
sirolimus. Okay, sirolimus. Sirolimus. Okay, so you can see that tacrolimus and sirolimus all like almost they rhymes, right? But the difference is that they won't bind to this factor. There is another factor that is called as FK. Okay, let me just see it from the first way. Okay. So the
FKBP.
sirolimus basically bind to FKBP, right? Blood pressure. Okay, FKBP, right?
BP. Yes.
FKBP. And then it's going to inhibit your mTOR. But the good, the good part of sirolimus is that it do not cause nephrotoxicity. It do not cause nephrotoxicity. So in the question stem, if they are just telling you we have, apart from using tacro, we are, using, sirolimus. What do you think? Why? Why? What's the good point which we are why are we using sirolimus instead of tacro? The only thing can be nephrotoxicity, right? If you have increased chances of nephrotoxicity, then you can just switch to sirolimus. And the idea is again same. If we are blocking of the mTOR, again we are directly inhibiting, but it's a downstream effect, right? You can see like it's like come very late in the pathway. Still, the T cell growth can be inhibited, right? But the two can come and anything can happen. Is it clear? Hello?
Yes, sir.
Yes.
We
Yes.
can do one other thing as well. Here, what if we just block this receptor? What if you just block this receptor? Again, we can achieve the same results, right? We can achieve same results, right? Either by blocking
Yes.
calcineurin, by blocking mTOR, or by blocking directly the receptor of interleukin 2. Okay, so the monoclonal antibody. What is monoclonal antibodies? The idea is really simple. We are going to make an antibodies, right, specific to this receptor. And what's going to be the effect of that antibody? It's going to block the effect of interleukin. Like it's going to act as a physical barrier, simple, right? So antibody is sitting
Yes,
here
sir.
now. Interleukin 2 cannot act there, and we won't be having proliferation of T cells. Basilux, right? Basilux. Whenever you see MAB in the
Fuzzy.
end, that's Basilux, I guess, right? That's something like that. Okay.
Yes. Yes,
Fuzzy.
Bacillus. Yes.
Okay. Okay. So these were basically the concept of the drugs which we discussed, right? So let's read it from the first aid. Do you guys have any questions?
No, doctor.
Okay, let's discuss. Okay, so cyclosporine, we know that it's a calcineurin inhibitor. It's going to bind with cyclophilin first, and once bind with cyclophilin, we are going to preventing the interleukin 2 transcription. You guys see, you can have this NFAD pathway, right? Here you can see. Okay, and as okay, so cyclosporine can be okay, the indications are going to be psoriasis and rheumatoid arthritis. So how do you want to remember this, a really interesting way in which I just remember it, right? For example, if you have a cyclist going on, in a sunny environment, right, or a sunny kind of day, right? So if he's just cycling too much, his joints can be affected and his skin can be affected, right? If he's cycling too much, right? So cyclosporin, two things to keep in mind: psoriasis, skin condition, and rheumatoid arthritis. That's all. Joints and
Yes.
skin are going to be affected if someone is, going in a sunny weather through, to just, you know, riding a bicycle simply, right? So cyclosporin for psoriasis and rheumatoid arthritis. Keep those things in mind, right? I just told you both of them causes
Sorry,
nephrotoxicity. Yes, please.
are they the side effects or
No
These
indications?
are the
indication.
indications. These are the indications, right? Rheumatoid arthritis, again, it's a kind of autoimmune
Autoimmune.
disease we'll be discussing. So, in that condition, we are going to depress the immunity in order to save ourselves from those autoimmune T cells or B cells, right? Is it clear?
Yes, sir.
Hello? Okay. So
Yes, sir.
nephrotoxicity, hypertension, hyperlipidemia, neurotoxicity, gingival hyperplasia, hirsutism. We discussed gingival hyperplasia, we discussed hirsutism, we discussed neurotoxicity, nephrotoxicity. Just add two things. Just add two things: hypertension and hyperlipidemia. Is it clear?
Yes, sir.
Okay. Perfect. The other was tacro, right? We discussed that tacro is first of all going to combine with FK506. Okay. As it combines, then it's going to inhibit your calcineurin. And as the calcineurin is inhibited, what will happen next? We are going to be having, the interleukin 2 cannot form and everything. You guys know that, right? So we are going to use it
Yes.
in solid organ transplantation, solid organs, kidney, liver, anything, right? So in the solid organ transplantation, in order to suppress immunity, we are going to use tacro. Is it clear? Hello?
Yes,
Okay.
sir.
Yes, doctor.
Okay.
Yes,
But
sir. Yes,
tacro
sir.
can cause diabetes, increased risk of diabetes. Keep that in mind. Okay. Again, neurotoxicity and nephrotoxicity was common in both of those drugs. No gingival hyperplasia, no hirsutism in case of tacro. That is only going to be seen in cyclo. Is it clear?
Yes, sir.
Hello?
Doctor.
Perfect. Yes, so you guys can see both calcineurin inhibitors are highly nephrotoxic, especially in higher doses in patients with decreased renal function. We already discussed that as well, right? The next one
Yes, sir.
was sirolimus, right? Sirolimus or rapamycin. Rapamycin. We discussed its mTOR inhibitor binding to FKBP, right? And what would it
Yes,
do?
sir.
It would block T cell activation and growth and everything, Okay. Okay, so in kidney transplantation, we are going to be using that because it have decreased, effect on it. Do not cause nephrotoxicity, as I already mentioned, right? So you
Okay.
can see it would
Yes,
cause
sir.
pancytopenia, insulin resistance, hyperlipidemia, and no nephrotoxic. It isn't. So the high yield one is not nephrotoxic, right? Pancytopenia can be seen in a lot of immunosuppressants. So that you won't ever be tested on pancytopenia, believing that. Okay, so insulin resistance as well. So just keep those in mind. So kidney survey, if they have just given a mnemonic. Okay. Okay, that is bacilliximab, right? Okay, we discussed
Yes.
bacilliximab is directly going to, sit on the receptor. Interleukin 2 cannot act there. And as the interleukin 2 cannot act there, we won't be having growth of T cells. Okay, so what are the adverse effect of their toxicity? Edema, hypertension, tremor, right? Bacilliximab, right? Edema, hypertension, and like you can imagine a fluid overload with basil seeds, right? Have you guys
Yes,
ever,
sir.
use basil seeds in drinks or something like that? So you can just imagine it would cause a lot of edema, a lot of hypertension, and in the end, tremors, right? Okay.
Yes, sir.
So let's
Indication
discuss.
is not
Okay.
written down.
Okay. No. Sorry, no indications are mentioned here. So this is the only thing which you should just keep in mind. Okay. So let's discuss our next one, that is azathioprine, right? Azathioprine, mycophenolate, and glucocorticoids. So let me just make it really easy for you guys. Okay. So you won't be remembering, these pathways, and let me just make it really easy and really understandable, right? Azathiopurine, preen for purines, right? We know that purines are important for making your DNA. Am I right? Purines and pyrimidines,
Yes, sir.
right?
Yes, sir.
Purines are
Yes, sir.
really important for making your DNA. We know that. For example, if I'm not letting purines to be made, can I make DNA?
Difficult. No.
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 If I cannot make DNA, can I cause? Okay, so can we have cell growth if you do not have DNA?
No.
No.
Cell is going to be dead if you do not have DNA, right? So, for
Yes.
example, if it's T cells, so won't you think that the cells are going to, that they won't grow if you are just, inhibiting the purines, right? Inhibiting we are inhibiting, formation of DNA because purines are important for DNA formation, right? So what azathioprine do whenever you administer it, it would change into something called 6-mercaptopurine. 6-mercaptopurine. And what this 6-mercaptopurine is going to do, instead of the nucleotides basically make your purines, right? So instead they're going to compete with those nucleotides, and they're going to sit there in the in the chain. For example, if I'm just making a lot of purines, right? So I'm constantly adding nucleotides to that, right? So what your 6-mercaptopurine is going to do is going to knock off, it won't allow the nucleotide to add into that chain, and it will just come, it will just sit there. And once it sit there, it won't let proper purine formation. If it do not let proper purine formation, we won't be having proper DNA formation. If you do not have proper DNA formation, the T cell there is going to be dead. It cannot proliferate. Does that make sense? Hello?
Mm.
Yes,
Hello?
sir.
The same phenomena was for other two drugs, methotrexate. Do you remember for the DNA formation, we require dihydrofolate, right? Hello?
Yes.
Hello? If
Yes.
I'm not allowing that dihydrofolate to contribute in formation of DNA, again the cell is going to be dead there, right? Trimethox, that's something like what trimethoxim sulfate or something like that. That's a same kind of it have same phenomena of methotrexate, but that's going to be used in bacteria or bug in order to kill their DNA. And once the DNA is killed, the bug is also going to be killed, right? So these are the concepts which you should just keep in mind. What azathioprine is going to do, azathioprine is going to be converted into 6-mercaptopurine, and 6-mercaptopurine is going to inhibit the proliferation by blocking the nucleotide synthesis. Is it clear?
Okay.
Yes, sir.
Okay. Okay, just give me a second. Okay. So remember one thing, really important, really high yield. Okay, till now we discussed the azathioprine, we discussed 6-mercaptopurine. Remember an enzyme that was xanthine oxidase? Do you guys remember that? Xanthine oxidase.
Yes,
Yes.
yes. For formation of
Okay.
uric acid, the
Yes, formation of uric acid. If an individual is having that, suppose if an individual is having any kind of gout, right? That is a lot of uric acid. We were basically giving something called allopurinol, which was basically inhibiting your what? Xanthine oxidase, right? And once
Yes.
we inhibit xanthine oxidase, then we were just stopping the entire pathway for conversion or making of your uric acid.
Yes.
Remember, this 6-mercaptopurine is also being metabolized by the same enzyme xanthine oxidase, right? This 6-mercaptopurine is going to be, you know, metabolized by same enzyme, that is xanthine oxidase. So, for example, if you have an individual with gout and
Doctor,
we are giving them,
can you repeat this, please?
okay, okay, let me just repeat it. Okay, we discussed azathioprine, right? We discussed it's going to be converted into 6-mercaptopurine, right? And as it's converting to 6-mercaptopurine, it's going to stop the nucleotide getting into purine bases. It won't allow the DNA formation. And if you do not have DNA, the cell is going to be dead. It's going to be killed, right? Okay. We discussed that in uric acid formation, you are having guanosine, you are having hypoxanthine that was just converted by an enzyme, xanthine oxidase. In the end, we were having uric acid, right? So if you guys remember a pathology gout, what is gout? Whenever we have a lot of uric acid being formed, right, from the purine, metabolism and everything, we're going to get gout. And one of the treatment options for gout was allopurinol. Allopurinol was basically inhibiting the same xanthine oxidase enzyme, right? So that's why we were just stopping the formation of uric acid. Like in the gout, we discussed that the uric acid can just enter into the joints, they can form crystals, they can cause inflammation there, and a lot of joints problem, right? So what's one of the treatment option for that? Just inhibit xanthine oxidase. We'll be having less uric acid crystals in the joints as well, and as a result of that, we will be resolving the problems. But this same enzyme is also used to metabolize your 6-mercaptopurine. Is it clear? So in an individual who is already on allopurinol, an individual who is already on allopurinol, for example, if he's having any kind of gout, right? So we won't give him azathioprine because still we are inhibiting this enzyme. We can have toxicity of 6-mercaptopurine. Does that make sense? Because now we cannot
Yes.
metabolize 6-mercaptopurine as well. That is going to build to the toxic levels. And once it's built to the toxic level, it can cause a lot of killing of your cells, T cells, B cells, anything, right? Okay, so you guys can see it here. Where do we use azathioprine, right? Azathioprine is basically used in rheumatoid arthritis, Crohn's disease, glomerulonephritis, and autoimmune conditions, right? These are the things which you should just keep in mind. We discussed that 6-mercaptopurine is degraded by the same xanthine oxidase, right? So increased toxicity in allopurinol. I think that's clear, right? Hello.
Yes,
Yes.
sir.
Okay, do you guys have any questions?
No, doctor.
No.
Okay, perfect. So now let's discuss mycophenolate, right? So for that, let's just discuss this pathway a little bit, right? So once azathioprine is given, it's going to be converted into 6-mercaptopurines, by an enzyme PRPP aminotransferase, right? It's going to transfer it here, and in the end, you're going to be having IMP dehydrogenase, right? And then you can have like all of these are basically helping in formation of your purine, right? So 6-mercaptopurine basically inhibits the PRPP enzyme. That's why we do not have purine, nucleotide and formation of DNA if we are blocking them. So we also have another enzyme in the same pathway that is IMP dehydrogenase, right? IMP dehydrogenase. So mycophenolate basically inhibits IMP dehydrogenase. And once that is inhibited again, we won't be having purine for nucleotide formation. If you do not have purine, we won't be having DNA, we won't be having DNA replication, the cell is going to be dead. Is it clear? So you have two enzymes to keep in mind, PRPP, IMP, right? Okay, is it
Yes,
clear?
sir.
So you guys can see it here, like what this mycophenolate is going to do. It's going to be reversible inhibiting your IMP dehydrogenase, preventing purine synthesis and in the end B and T cells death or synthesis, right? Okay, so it's a glucocorticoid sparing agent in rheumatic disease. If you aren't giving like glucocorticoids in a rheumatic disease due to any kind of inflammation, so you can give mycophenolate in that as well, right? So what the toxicity would cause? It would cause GI upset, pancytopenia, hypertension. It's less nephrotoxic and neurotoxic. It's something you have to memorize. Okay, GI upset, GI upset, and it make a lot of sense as well, right? Why are okay? Let me just tell you some concept, right? How to remember these things. Okay, whenever we give the drugs which lead to less DNA formation. So most commonly we are going to be having the effect on those cells which are rapidly dividing cells, right? Because rapidly dividing cells need a lot of DNA activity. Does that make sense?
Yes, sir.
Yes.
Hello.
Yes.
Okay, so what are your
Yes.
rapidly dividing cells? Rapidly dividing cells can be your blood cells. You know, okay, it can be your epithelial cells. So if you are giving these things, GI upset, epithelium is going to be disrupted. This is the way you can just make sense of these things, right? Pain, cytopenia,
Yes, sir.
hypertension as well, right? Okay, and they are less nephro and neurotoxic. You have to remember that. Okay. So the associated with invasive CMV infection. If you are just suppressing the immunity, so CMV is going to be the virus, infecting those individuals. I think that makes sense. Okay. So the last one is glucocorticoids and really, really high yield. If you guys remember the acute inflammatory pathway, the DAMP and the PAMP, remember?
Yes.
Hello?
Yes, sir.
Yes, sir.
On
Yes,
the
sir.
neutrophils, we were having a receptor. What was the name of that receptor? Toll-like
Yes.
receptor. Remember?
Yes,
Hello?
sir.
Toll-like receptor was able to recognize two things. Toll-like receptor was able to recognize the PAMs or DAMs. Once it recognized the PAMs, once it recognized the DAMs, it was basically activating something called nuclear factor of kappa, okay, KB and FKB. And once that was activated, it was releasing three things: interleukin 1, interleukin 6, and TNF alpha. Remember these three things? Hello?
Yes, sir.
Okay, so what your glucocorticoids are going to do, they are steroids kind of things, right? So they can directly cross, like dissolve, like if you are giving steroid, they can easily cross the, the cell, the T cell membrane, right? Because like dissolve, like they also have these components, the steroid, they can easily get dissolved. Once they enter, they would inhibit NFKB. If the NFKB is inhibited, you won't be having the T cell function is going to decrease cytokines. Which cytokines? Okay, the interleukin 1, interleukin 6, and TNF alpha. All of them are going to go down, right? Okay. So why do we? Okay, what are the indications? You guys know that asthma, adrenal insufficiency. Remember CLL. We will be discussing CLL in our hematology section. Dr. Moaz is going to do that. Non-Hodgkin lymphoma again. It's a topic of your hematology, right? In the white blood cells module, you guys are going to do that. Okay, and inflammatory disorders. Okay, if you are giving glucocorticoids, you guys have done your endo, so we'll be having Cushing syndrome, right? Yes or no? Hello?
Yes, sir.
Yes.
It's
Yes,
going to
sir.
cause osteoporosis. Why? Because we discussed that glucocorticoids basically,
Activate the osteoclast.
activates your osteoclastic activity via rank receptor and everything. Hyperglycemia, it's a stress hormone. So it would cause
Cortisol.
hyperglycemia. In the U world, you are going to be seeing an MCQ. You are having an individual with this, and that condition. We gave them certain drug. He was having hypercalcemia due to bone destruction. Keep that in mind, okay? He was having like that's osteoporosis. You were having hyperglycemia as well, okay, okay, and it was just causing diabetes as well, you know. Okay, amenorrhea, it can also cause amenorrhea as well. We discussed that in our endocrine section, right? Adrenocortical atrophy, because it's going to inhibit ACTH. ACTH is inhibited, we are going to be having bilateral atrophy of your adrenal glands, remember? And really
Yes.
high yield avascular necrosis of femoral head. You're going to see thousands of MCQs in a lot of systems in your MSK. They're going to tell you are having an individual with SLE. You are giving him some, you are giving him glucocorticoids, and on the X-ray he was having some, what was, and the answer is going to be avascular head necrosis. Keep that in mind, avascular necrosis. It's going to compromise the blood supply to the femoral head, and as the blood supply to the femoral head via the circumflex artery, we are going to do the entire anatomy in our MSK section right after your hematology. And as we have, decreased blood supply to the head of femur, it's going to lead to necrosis. That's so simple, right? So this condition is basically called as avascular head necrosis of your femoral head. Okay. We discussed something, if you guys remember, in our endocrine section. We have something called marginated pool. Remember the bags sitting in your pulmonary blood vessels. Remember the neutrophils.
Yeah. Yes.
Remember with adhesion molecules, and we discussed that the glucocorticoids, they are going to knock off those adhesion molecules through which your neutrophils are hanging from the blood vessels in your pulmonary vasculature. So what would happen as a result of that? All neutrophils are going to enter into the blood. As they enter into the blood, we'll be having neutrophilia, right? A lot of neutrophils in the blood. Okay. Hello.
Yes.
Yes.
Okay. Okay, what else we discussed? We discussed in adrenal insufficiency, we can give glucocorticoids. Why? Because it's adrenal insufficiency, we do not have cortisol, let's give glucocorticoids. So these are all of the things, okay, your immunosuppressants. Hope so, it's clear. Okay,
And sir, what is the pathophysiology of steroid-induced psychosis?
steroid induced psychosis.
Yes.
Okay, so steroid. Okay, we are going to discuss the exact pathophysiology somewhere in the neuro section. But we are going to do that there. Like, still, I do not remember the exact pathophysiology, right?
Okay, sir.
But I'm going to
Thank you.
tell you there, okay? Once we're just
Doctor,
doing the system. Yes, please.
can you summarize the glucocorticoids mechanism one more time,
Okay.
please?
Yes. Okay.
Thank
Let me
you.
just summarize. Glucocorticoid. Okay. Before glucocorticoids, you should know, the acute inflammatory pathway, right? Acute inflammation. How does acute inflammation occurs? Okay. So let me just discuss that pathway, right? Okay. So, for example, if this is your neutrophil, so the neutrophils have something called toll-like receptors. Okay, toll-like receptors. Okay. So what happens that once the DAMP and the PAM come, we discuss damage-associated molecular pattern, DAMP and PAM. Okay. Once they come, they're going to activate the toll-like receptors. Once the toll-like receptors are activated, what they would do, they would just cause, okay, once they're activated, they're going to cause the NFK beta, right? And once NFK beta is activated, it's going to go into the your nucleus, there into your DNA, and it's going to make interleukin 1, interleukin 6, and TNF alpha, right? So the function of interleukin 1, it's going to cause the increased temperature, interleukin 6 acute phase reactants, and TNF alpha. What TNF alpha is going to do, it have a lot of functions. It's going to cause vasodilation. It's going to maintain the granuloma. It's going to make the cacectin and everything. If you guys remember, we did it, right? Hello. So if you are blocking off, hello.
Yes, sir. Yes, sir.
Yes.
Following.
Okay.
Yes, sir.
If we are blocking of this pathway, it means we are decreasing the acute inflammation, right? We are decreasing inflammation. We are decreasing inflammation. In which condition we see inflammation? Inflammation can basically be seen in asthma, so that's why we give glucocorticoids in that. It can be seen in a lot of condition like non-Hodgkin lymphoma, CLL, and everything. So this was basically the mechanism of action of glucocorticoids. Is it clear? Hello.
Yes. Thank you.
Yes, sir.
Okay, those
Yes,
who
sir.
are with me from the previous marathons and from the previous classes, you guys know that I do not teach pharmacology, right? You guys know that, right? But since
Yes.
I'm just trying my best, okay, because I had pharmacology. Okay. Okay. So that okay. Okay, you were discussing something, the glucocorticoid induced psychosis, right? Hello.
Yes, sir. Yes, sir.
I
Yes.
can just relate it with a pathology. I can just relate it with a pathology. Remember, we have something called SLE, right? Okay, have you guys did
Yes.
SLE? No, I think
No.
you guys haven't done SLE. It was basically it's a topic of immunology. Do you guys want me to do SLE?
We have some idea. Yeah.
We did
Please,
it.
please.
Yes, we want.
Okay, so let's do SLE after this topic, right? So you have erythropoietin. I think these other are really simple. Just read it from the first slide. What's the function of erythropoietin? You guys know that. In anemia, we are going to give them choline stimulating factor. These three. You can just do that. But let's start our SLE, right? So in SLE, basically, we are also going to see psychosis, right? Psychosis. Remember, and the psychosis was not basically due to SLE. It was basically due to drug-induced psychosis, right? So let's do that there, okay? Let's do SLE first, and then we can just, I'll just tell you the association with how do it cause psychosis, okay? So, okay, so let me just open my pathoma. So let's do SLE from pathoma, okay? Just give me a second.
ياسين میشه لطفا آره میشه دار میخوره آفرین
Okay, those who do not have their pathoma, just please take your pathoma. We are going to discuss some, SLE from there. It's a big topic, so I want you guys to have your pathoma in front of you. I'm also opening my pathoma, so just give me some time, please.
Sir, after that, can you please explain type 2 hypersensitivity from the FA?
Sure, sure. I'm going to explain that. No problem.
Sir, page number, pathoma.
I
I'm
think page
also
number
searching that.
18.
Okay, if someone know the
18.
page
18.
number, please tell me as well. Okay.
18. 1 8.
بخوره آفرین
Yes, page number 18.
It's page number 18 or 80?
18, 1-8.
18, 1-8.
1-8. Okay, just give me a second. My pathoma is loading. I'm just opening it from an online PDF. Just give me a second. Hello. Can you guys just see my screen? Hello.
Yes, sir.
Yes.
Okay. Okay. So let's discuss SLE, systemic lupus erythematosus, right? If you guys remembered, I have just told you the the basic concepts. Why are we going to see have this lupus? If you guys remember, I just did it in early complement deficiency. Remember, but let's just summarize that again, right? Okay. I just told you that, for example, if you have an individual, it's a skin. Skin consists of keratinocytes, right? For example, if the sunlight falls on the skin, the UV radiation, right? It would knock off the DNA, right? And as the DNA is knocked off, we know that the cell is going to die. It's going to undergo apoptosis, the pycnosis, karyolysis, and everything. And the DNA component is going to release outward, right? In order to clear off the DNA, your IgG is going to come. Okay, this is your DNA. Your IgG is going to come. It's going to bind to DNA. It would just form something called immune complex, right? Okay. And it was basically the goal of your complement system in order to clear this immune complex. Is it clear? Hello?
Yes.
Hello? But if we have any kind of complement deficiency, if we cannot clear off this immune complex, so what happens? The level of these immune complexes are going to build up, right? And as the level of these immune complexes build up, it's going to deposit in different places, right? It's going to deposit in the skin, it's going to deposit in the kidney, it's going to deposit, in the serosal surfaces, it's going to deposit in a lot of places. And as they get deposit, let's suppose in this case in kidneys, right? If you guys remember, we did this pathology in our renal section, remember? So as they get deposited there, what will we see there? The local complement system is going to get activated, but the local complement system still isn't able to destroy these antigen antibody complexes, right? Okay. So what the component of the complement system is going to do is going to attract a lot of neutrophils, attract a lot of inflammatory cells, and that's going to cause destruction of kidneys in this case. Okay. So that's going to lead to glomerulonephritis. What is the most common cause of death in individual with SLE? Renal failure, right?
Renal.
Renal failure, right? So these antibodies, antigen complexes can cause problems in 11 places inside your body, right? In 11 places, right? 11 places. Okay. So can I say that it's going to be mostly due to type 3 hypersensitivity? Hello?
Yes.
Yes, sir.
Yes,
Yes.
yes.
Mostly it's going to be due to type 3 hypersensitivity. But we can also have type 2 hypersensitivity, right? So one of the doctors just told me to explain type 2 hypersensitivity. So let's just discuss type 2 hypersensitivity as well. What we discuss in type 2 hypersensitivity is that we'll be having antibodies, right? Those antibodies would just go, and it would just, let's suppose, it would just go. For example, let's just take an example of type 2 hypersensitivity. That is autoimmune hemolytic anemia. Let's take that as an example, right? So what would happen? It would attach itself to the red blood cells, and as they get attached to the red blood cells, it would just call upon your inflammatory cells. And as the inflammatory cells, your complement system specifically So the complement system is going to come there and it's going to lead to destruction of your red blood cells, giving you hemolytic anemia. Is that clear? Hello?
Yes.
Yes, doctor,
Okay.
Yes,
but
sir.
So remember, in,
there are three components in FA. I am unable to understand.
okay, so do you want me to do that first? Okay, let's do that.
Yes.
Okay, type 2 hypersensitivity. Now, we discussed that it's going to be antigen. Okay, antibody is directly going and attaching to the surface of, for example, we just took an example of red blood cell, and it would just call upon two things. Either it would call upon the complement system to cause destruction, or either it would just call upon the natural killer cells to cause destruction, right? Two things. Okay, antibodies attached to the surface, it can call two things. It can call either your complement system to come there and cause destruction, or you can call your natural killer cells to come there and cause destruction, right? Is it clear? Hello?
Yes, yes, doctor.
If you guys remember the classical pathway, how we do activate the classical pathway that was activated by your IgG antibodies, right? So this is the same classical pathway that antibodies are activating your complement system. But whenever the antibodies are attached to the surface of anything, that's a type 2 hypersensitivity. It can cause a lot of these antibodies can not only cause destruction. It can do these antibodies can do three things. Remember, okay? These antibodies can either cause destruction. Okay, these can either cause destruction. How do they cause destruction? They will just call the complement system, or they will just call the natural killer cell to come and cause destruction. Okay, this is the first thing which these antibodies can do. What's the second thing? These antibodies can come, these can attach to certain receptors, right? And they can increase the activity of the receptors, increase the activity of receptor. For example, what's the example of this condition? Graves disease, right? We discussed in Graves disease, we are going to be having certain antibodies like IgG attaching to the receptors and increasing the activity of that receptor. In the end, we are having a lot of T3 and T4 hyperthyroidism, right? Hello? So the second thing is it can cause stimulation, it can cause increased stimulation of the receptors, it can cause increased activity of a gland, for example, you discussed in Graves' disease. What's the third thing these antibodies can do? These antibodies can go and they can just sit on the receptors, and once they sit on the receptor, they would decrease the activity of the receptor. And what was the example of that? Example of that was myasthenia gravis, right? Myasthenia
Yes, sir.
gravis. In myasthenia gravis, what these associated with thymoma, remember? Hello?
Yes, sir.
Yes, sir.
Yes,
Hello?
doctor.
Okay. So associated with thymomas. So these are the three things which these antibodies can do. Just keep in mind. It can either cause destruction once it bind to any surface, anything like, for example, a good pasture syndrome was also an example of type 2 hypersensitivity. Remember? Hematuria,
Yes, sir.
hemoptysis, we did that, right? So either it can cause destruction. How? By two mechanism: calling your complement system to cause destruction, or calling your natural killer cells to come there and cause destruction. It can either stimulate the activity of receptors. For example, Graves' disease. It can inhibit the activity of receptors. For example, myasthenia gravis, Lambert-Eaton, right? In Lambert-Eaton, we are having antibodies against calcium receptors, right?
Yeah,
And
presynaptic
Yes.
calcium
Lambert-Eaton,
Yes.
receptors.
yes,
Presynaptic calcium. Yes.
associated with which carcinoma? We did that.
Small cell carcinoma
Small
lung.
cell carcinoma.
Small
Small
cell
cell lung
carcinoma.
carcinoma.
Small cell.
Is yes. Is it clear? Type 2 hypersensitivity?
Yes, doctor.
Oh, well. So we were discussing SLE, right? So SLE can have type 3 hypersensitivity. That is antigen antibody complexes being formed. They are going to increase in number. They can deposit in different tissues, and as they deposit in different tissues, they can just activate the local complement system and can lead to destruction of your, let's suppose if it's kidney. So remember, in SLE, these antigen antibody complexes can affect 11 systems. The concept is same. They're going to deposit there. They're going to call upon the complement system, and the complement system hence is going to lead to destruction. So you can just see it here. Okay, where is my pathoma, right? So you can see it's both, and we are going to see both type 2 and type 3 hypersensitivity. Remember, in SLE we can have sometimes formation of certain, and it's an autoimmune condition, right? And remember one thing: autoimmunity is most commonly going to be seen in young female, right? Young female. In the history, you are always going to see young female, right? Okay. Hello.
Yes, sir. Yes, sir.
Okay. So, how does type 2 hypersensitivity work here in SLE? Remember, in SLE, certain antibodies can be made against your blood cells, which can cause pancytopenia, right? So, the pancytopenia seen in this condition in SLE is due to type 2 hypersensitivity. That is, the antibodies coming directly and binding to the surface of, let's suppose, red blood cells, leading to its destruction. So, it's both a mixture of type 2 and type 3 hypersensitivity. Is it clear? Hello?
Yes.
Like we can,
Yes, sir. Yes,
like
sir.
it can lead to destruction of your erythrocyte, it can lead to destruction of your white blood cell, destruction of your platelets. So it's a pancytopenia, right? When all of the cell lineages are going down. And the example, and we already know that. How do it occurs? The antibodies are going to be made against these, erythroblasts or erythrocytes, the platelets, the white blood cells, and it's going to lead to destruction, either activating your complement system or activation of your, natural killer cells, right? So we can have 11 systems being involved here. Let's just do that. These, you can just simply think of these antigen and antibody complex can deposit in the skin as well. And as that skin is exposed to sun, it's going to give you malar rash. What is malar rash? It's basically a, okay, what's
Butterfly
malar rash?
rash.
Butterfly rash, right? Okay, it can also get you discoid rash. Discoid rash is basically a circular kind of rash, on the skin, a circular kind, right? Okay. So the malar rash, fever and weight loss, obviously, we are going to have inflammation there. It's going to cause fever and weight loss as well. Pleuritis and pericarditis. The serosal surfaces can also be affected. You can simply imagine that these immune complexes can go, they can deposit in the pericardium, they can deposit in the pleura, causing inflammation there, activation of your complement system, inflammation of pericardium, and inflammation of your pleura, giving you pleuritis and pericarditis, right? CNS psychosis. CNS psychosis. So this was the thing which I was discussing. The CNS psychosis is not the direct impact of SLE. It's basically the side effect of the drugs which we are going to give in SLE, right? So in SLE, what do we give? We give glucocorticoids, right? We need immunosuppression, right? We need to suppress the immunity because the immune cells are causing problem, right? So we are going to give the glucocorticoids in this condition, right? In order to decrease inflammation everywhere, right? Am I right?
Yes.
Hello? Okay. So how
Yes,
do it
sir.
cause psychosis? How do glucocorticoids cause psychosis? One of the doctor asked me an MCQ. You know that the glucocorticoids are steroids, right? They can cross the cells. They can cross the brain as well, right? Hello?
Yes.
They
Yes,
can
sir.
cross,
Yes,
cross
sir. Yes, sir.
blood-brain barrier, right? And as they cross blood-brain barrier, it can cause a lot of problems, right? For example, it can. Okay, why do we get psychosis? You should know that we get psychosis in a condition known as schizophrenia. If you guys remember, right? Schizophrenia. Whenever you see psychosis, the first pathology which you should just come in mind is schizophrenia. What happens in schizophrenia is we are going to be having a lot of dopamine concentration, everywhere in the brain, right? Okay, and that increased dopamine is going to cause psychosis. Is it clear? Yes or no? Okay.
Okay, sir.
So
Thank
what
you.
the glucocorticoids do? Glucocorticoids can directly cross the blood-brain barrier. It can, like from where do the dopamine come? In this way, you can just link things, right? As it can cross the brain, it can enter to the dopamine. Okay, it can just cross the blood brain barrier, and as it crosses the blood brain barrier, it can increase the dopamine's level. From where do the dopamine come? We know that substantia nigra, right? Pars compacta, pars reticularis. From the compacta part we get increased dopamine, right? So in this way, glucocorticoids can cross blood brain barrier, that can interact with different neurotransmitters, that can increase the dopamine level, and as they increase the dopamine level, we are going to be having psychosis. Is it clear? Hope so. This is the answer to your question.
Thank you, sir.
Okay, just keep that in mind. So CNS psychosis in SLE, basically, I was just talking. It's not directly due to SLE. It's basically the adverse effect due to the medication we are using for SLE. For example, the glucocorticoids. Is it clear? Hello.
Yes.
Okay. Yes, sir.
Okay. We discussed we can have renal damage as well, right? So how do we have renal damage? We discuss immune complexes can deposit there in the glomerular basement membrane. They can just activate your complement system. And as the complement system get activated, it can lead to destruction. Okay, so the kidney failure is most common cause of death in patient with SLE. That's all. Okay. We discussed, okay, Liebman-Sack endocarditis. You guys cannot, you guys must know Liebman-Sack endocarditis in the section of cardiovascular. I just told you, whenever we have endocarditis, okay, and okay, it's not basically a real endocarditis having any kind of bacteria. I just told you, whenever we have, let's suppose, a tuft of platelets and fibrin sitting on the on both surfaces of your mitral valve, what should be your diagnosis if it's on the both surfaces of your mitral valve?
Yes, then Libman sac
Lemon
endocarditis.
sac.
Liebman-Sack endocarditis, both surfaces, right? Both surfaces was
Yes,
really
sir.
important. No, mostly we are going to be having regurgitant murmur in our, in our endocarditis. Why? Because we discussed on the top of mitral wall that these vegetation can sit and won't allow the wall to close. So that's why we are going to be having regurgitation. But there you were having an MCQ in you word, if you guys remember. They were asking you, we have an individual, we just, we cut his heart, we just look towards his mitral wall, and we were having vegetation on both sides. What's your diagnosis? Diagnosis was Lehman-Sack endocarditis associated with systemic lupus erythematosus, SLE. Why? Because in SLE, we can have hypercoagulable state. We can have a lot of platelets and fibrin activity. You guys might have done that with Dr. Moaz, the platelets activity. How do they get activated? The liver factor, GP1B, 2B, 3A, everything, right? Fibrin in between them, Glanzmann's thrombosphenia, Bernard Solier. Have you guys done that? Hello?
Yes, yes.
Yes.
Yes,
Okay,
yes, sir.
perfect.
Yes, sir.
Yes.
Right?
Yes.
So the hypercoagulous state, and we have like, vegetations or, platelets and fibrins upon both the surface of your mitral valve. That's already important. So I just told you the type 2 hypersensitivity is really important in SCD as well, because it's going to lead to direct destruction of your platelets, your white blood cells, your red blood cells. Okay. Okay. We have something called drug-induced lupus. Okay. Okay. So how to diagnose the lupus or SLE? We discussed that we are going to be having anti-DNA antibodies, right? We discussed that in the beginning, right? Anti-DNA antibodies, right?
Yes.
Mm.
Okay. But in the
It can,
drug-induced lupus, I just already told you we can have antibodies against histones. What were histones? I just told you that are just proteins which are present in your chromosomes, right? In your DNA, right? So in drug-induced lupus, whenever you see anti-histone antibodies, that's basically your drug-induced lupus. Simple, right? Which drugs can cause this problem? That is HIP. Mnemonic is HIP. I just already told you. Isoniazid, procainamide, and hydrazine, I guess, right? Hello?
Yes, sir.
yes.
Yes,
Okay,
sir.
can
Yes,
you
sir.
guys just tell me the fourth drug which can cause lupus?
Co- Quinidine.
It's quinidine. Yeah.
Mm,
Quinidine? Okay, the fifth one then. Okay, the drug related to your
Methyl dopa.
immunosuppressants.
Methyl dopa.
Okay,
Taxino.
okay, we did we are doing immunology, right? So I want you guys to tell me a drug related to your immunology, immunosuppressants.
Glucocorticoid.
TNF alpha inhibitors. Okay, we are going
Infliximab.
to do that. Okay, okay, what are TNF alpha inhibitors? Infliximab,
Infliximab.
golimumab, what else? Certolizumab, what
Adalimumab.
else? Adalimumab, something like that, right? Okay, so these are the things, right? You should just keep in mind. Okay, so we can have something called antiphospholipid antibody syndrome. Okay, so antiphospholipid antibody syndrome is a big topic which Dr. Mohas is going to discuss with you in in the hematology section. Okay, and then you guys can just read this, so it would be really easy for you guys to catch this, right? But one thing here which you should just remember, in this syndrome, we are going to be having hypercoagulable state, right? And as we have hypercoagulable state, we are going to see a lot of activity of your coagulation cascade. So it can do to a lot of thrombosis, right? Simply you can remember, why do we have that vegetation, Liebman-Sack endocarditis? That was due to hypercoagulable state. Why? Because we have antiphospholipid syndrome here, right? Okay. So we can have thrombosis of your of the hepatic vein. What's the name of hepatic vein thrombosis? What do we call that? Budd-Chiari syndrome, right?
But yeah,
But
Budd-Chiari.
Budd-Chiari.
Perfect. We can have placental thrombosis. If the placenta get thrombosed, the fetus is dead, right? So recurrent pregnancy loss and stroke as
then
well.
the
Okay?
phospholipid.
Yes. Yes. So they would require a lifelong anticoagulation, right? So that was all for your immunology, right? Pathologies we discussed. And if still you guys have any problems with any topic being left, so just let me know tomorrow. I'm gonna cover that, right? And don't worry for the you guys were asking for the boot camp session, right? So we are going to do it on next Sunday because we were having a lot of things left, right? So since we have done it, still, if you guys have any problem, in anything, so just let me know, okay? If it's your previous system, if you guys have any kind of problem, just let me know. So I'll just cover that, and we can have the bootcamp session then, okay? So hope so you guys enjoyed the session. Okay, so today it was really challenging for me discussing pharmacology with you guys, but hope so you understood. Okay,
Thank
thank
you.
you so much. Thank you, and have a nice
Thank
day.
you.
Bye.
Thank you.
Thank you.
Hello, can you please help me leaving the meeting? Dr. A, can you please leave the meeting?